opportunity, please use it.
I love to be a reviewer for Cephalalgia.
I love to publish in Cephalalgia.
Cephalalgia is the best journal.
The best journey to be actualized.
I read and publish in Cephalalgia.
Hi everyone, Cephalalgia says hello from Brazil.
الحقيقة بنتعلم من سيفالالجيا طول الوقت.
ودايما بنتعلم منها كل جديد.
मलाई सेफालाल्जिया मन पर्छ
मलाई Cephalalgia मन पर्छ.
Cephalalgia बहुत ही बढ़िया जर्नल है जो हम हमेशा पढ़ते रहते हैं.
Encuentro los artículos más relevantes en Cephalalgia.
Cephalalgia محبوب ترین ژورنال ماست.
我已经在头痛杂志发表过文章了，希望越来越多的人喜欢这个杂志。
من Cephalalgia'da داورم.
Cephalalgia باشترین ژورنال سرش است.
Eu leio artigos na Cephalalgia.
I think it's fantastic that Cephalalgia is open access, so the world has the best access and open access to the greatest research on headache that's out there.
Está sendo uma experiência muito enriquecedora estar aqui no Congresso Mundial de Cefaleia. I love Cephalalgia.
Hello guys, good evening. We are from India.
और हमें सेफालाल्जिया बहुत पसंद है.
And we love reading Cephalalgia.
I get met in Cephalalgia Sanertat.
Yo leo papers en Cephalalgia.
So, hello everyone, good morning. It's my pleasure to welcome you to this Cephalalgia and Jes Olesen Award sessions. My name is Simona Sacco. I am a professor of neurology at the University of L'Aquila in Italy, and I am the editor-in-chief of Cephalalgia and Cephalalgia Reports. I'm sure that you know rather well the journals, but I want briefly to take this opportunity to remind you the missions of our two journals. The mission of Cephalalgia is to publish the most novel and impactful clinical, translational and preclinical research to advance our understanding and management of all forms of headache and facial pains. Whereas the mission of Cephalalgia Reports is to provide a platform for the scientific publications that address the unique needs and challenges of improving headache management and education worldwide, with a particular focus on regional practice, educational initiatives, and diverse healthcare settings. This year we launched an initiative to accompany selected lectures with the simultaneous publication in Cephalalgia of a review article covering the lecture topics. We had this paper by the BA about decoding PACAP signaling, splice variants, pathways, and designer drugs. We have this second paper by Andrew Russo, PACAP versus CGRP in migraine, from mouse models to clinical translations. Deciphering mechanism, pathophysiology of migraine-related cognitive dysfunction by Raquel G. Gouveia. Optimizing combined treatment for the migraine and TMD disorders by Marcela Romero Reis. Impact of psychiatric comorbidity, resilience, and executive function on childhood and adolescence headache by Marco Arruda. Brain imaging in migraine with and without aura, similarities and differences, Gianluca Coppola. Reviewing the complex relationship between circadian rhythms and cluster headache, Andrea Carmine Bellin. Visual snow versus migraine aura, debate summary and novel insights into the syndrome by Francesca Puledda. Through the Eyes of Janus, remission and disease activity in cluster headache by Rolf Fronzek. Publishing papers in cephalalgia, it's a lot of work, requires expertise and requires the collaboration of our community and of our reviewers. Really, we want to express them our appreciation, and thus we are awarding our best reviewers. And I'm pleased to communicate that the top peer reviewer for the year 2024 was Dr. Bianca Raffaelli from Germany, and she has been invited to join the Cephalalgia editorial board as associate editor. And I want also to mention and to say a big thank you to our exceptional peer reviewers. Dr. Gregory Dussor, Roberta Messina, David Garzia Sorin, Raffaele Ornello, Ainur Ozgen, and Lanfranco Pellesi. Thank you, really, your work, it's much appreciated. We have also started training the next generation of reviewers, and the first year of the Cephalalgia Reviewer Academy was just completed last July, and here you can see the names of our new reviewers that have been trained. And we have started very recently the second year of Cephalalgia Reviewer Academy. This is really a nice story. We have positive feedbacks from those young fellows, and I'm sure that they will grow in our community and contribute to advance science and advance our mission. I want also to flag to your attention some IHS-driven papers that have been published over the last year in cephalalgia. We have the practice recommendation on management of migraine. We have one paper for acute treatment and the other for migraine prevention. We have the guidelines for the real-world evidence studies in migraine and in cluster headache. We have the evidence-based guideline for pharmacological treatment of migraine. We have the position statement on setting higher standards for migraine prevention. Recently, we have this position statement on transition of care from childhood to adulthood. And we have two accepted papers that will be published soon. It's the guideline on neuromodulation and the position statement on early migraine prevention. And we have several other initiatives that you can see in the slides that are in the pipeline, and you will see them published in cephalalgia next year. And I think this is something nice and important to advance our community and the way we treat patients. Now let's go to the Cephalalgia Award. Cephalalgia Award, it's the best paper published over 2 years in the journal. It is selected by the editorial board members, and I'm really pleased to announce that the winner of the 2023-2024 Cephalalgia Award is the paper entitled Functional Brainstem Representation of the cervical of the human trigeminal cervical complex, authored by Arne May and his group. Please, Arne, come on stage. An applause for Arne. Congratulations, really well done. Arne is a professor of neurology at the Department System Neuroscience at the University Hamburg. He is one of the leaders in headache research, in cluster headache, and in neuroimaging. He has been the editor-in-chief of Cephalalgia from 2016 to 2023. So, Arne, congratulations. The stage is yours.
Thank you, Simona. Hope everyone can hear me nicely. Welcome. I have to say thank you to you and also thank you to, of course, to the old and the new editors of the journal that I love, Cephalalgia. And I'm really honored that paper was awarded the Cephalalgia Award. Of course, now I give a talk about this paper, and first I need to then show you my conflict of interest. I have little, and none of them has anything to do with the work that I'm going to present. Science starts. So, how does science start? Since 70,000 years, it always starts with the same situation, that someone says, "Heh?" or that person says, "What?" or "Why?" And this is how it starts. And then this person starts to do things, and what this person then does, that is what we call science. And that started probably with finding fire. Someone saying, "Heh?" and then "Why?" and "How?" and "Can I do the same thing?" and then they had fire. In my case, and that for this story, it was neither a "Heh?" nor a "Why?" or a "How?" My story starts with a problem. So you know that I'm doing functional imaging, trying to map what is the difference between someone having a migraine versus someone not having a migraine, a cluster headache, and so on. And the problem in my case has to do with onions. And I thought I already alert you now that onions play a role, and I put that here as a little picture, and I later explain what I meant. This picture is old, you know, all about migraine and the brainstem. And we know that the brainstem is a pivotal site, obviously, for headache. We know that there are specific generators that have been identified in migraine and trigeminal headaches. However, the exact position of these brainstem nuclei are not known. Our imaging wasn't good enough to really, on a millimeter, exactly say where we are. And there's little information about scientific networks. And if you just look through these red and yellow pictures here, you can see that it always pinpoints the brainstem. However, always on different even heights. Now the question is, which one of them is true? If they are all true, which one is the most important one? And what does it tell us in our way how we think that migraine starts? However, since we know that the brainstem is so important in migraine, people started to look for symptomatic migraine. So a lesion in the brainstem, and then the migraine comes up because of that lesion. And here you see just some of these case reports. And I put a little white dot to all of these lesions. So all of these patients, individual patients, did not have a migraine in their past. They got this kind of lesion, either an inflammation or an infarction, and later they had the full-blown IHS classified migraine. And it was a brainstem, so everyone said, we understand now better what's happening. But if you look really at these pictures, you see it's always different heights. Sometimes you see the vestibularis coming out, sometimes the trigeminal nerve going, sometimes you see the brainstem and sometimes you don't. Which of these now, if that explains how migraine starts, then why does it explain that in patient 1 but not in patient 3, who has a completely different lesion or different site? That was the problem I was struggling with. So as a facet, functional imaging demonstrated definitely that the brainstem plays a pivotal role in migraine attacks, but it did not clearly pinpoint to the exact brainstem location. So thinking about it, this problem, we tried to come up with a solution. And the solution in that case, here you see the anatomy again. So you see where in the brainstem the trigeminal nuclei are situated. And you can see quite nicely that the first relay station would be the principal nucleus, exactly where the trigeminal nerve goes into the brainstem. Here you can see that in blue, and it detects touch. Whether you yourself or someone touches you, that would be transmitted there. Then we have the mesencephalic nuclei. They're going rather up in red, and they are going for proprioception. So for you to know where your jaw is in the three-dimensional space in correlation to your tongue, for example. The principal nucleus would be touch, you have the proprioception, and then you have the motor nucleus sitting just in between, and that would be the motor function. Now the pain, that's different. The pain is called the spinal nucleus, it's in green, and it really goes down to the level of C2. And you can see here quite nicely, and I put it on the right-hand side, left-hand side from your side probably, that the ophthalmic division here would be represented on the most lowest part of the spinal nucleus. The mandibular part, this part, would be on the highest part, more to the rostral, to the nose, and in between would be the maxilla. Now, a headache, of course, if we hit ourselves here, like Jes Olesen obviously yesterday did, when you feel that as a pain, then that would be transmitted down to the very lowest level of spinal nucleus and then goes up to the thalamus. Knowing this, we wanted to put that into the MRI scanner environment. And as you know, it's not allowed to put anything into that magnetic field that is either electric or is magnetopheric. We used here custom-made cables that had in between up nearly 50 transistors to make sure that we are allowed to put that into a three. That was a lot of propedeutic work that we did beforehand. That was with copper wire and wasp electrodes, and then now we were in the position to put a wasp electrode here, here, here into the back, and then stimulate just a very small, tiny pinprick of the respective area. We put a lot of people into the scanner, and you can see here that they went through 3 different sessions, and they always got pinprick here, 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 and here. It was always painful, and that was randomized 30 times per session. In the pilot study, we had 25 patients, and we did not publish that. But we had an outcome, and we took that outcome as a hypothesis. And we did a pre-registration, meaning that now we published where exactly we think we should find something. And now then only we did the original study that was 36 volunteers, and 22 of them were female, and they got, as I said, these 4 electrodes again on the first, second, third division and the GON. Stimulation site was randomized, and just like in the pilot study, each site was stimulated 10 times. On the left-hand side here in the box, you see that we used a specific situation how to look at the brainstem, because the brainstem is rather small. And to get the most out of it, we did not look at the all over the head. We only had a field of view of the brainstem up to the level of the thalamus. That allowed us, with looking also into denoising filters, and so allowed us to have a very small filter, and then because of that we could smooth these data that we had very little, and then the location, what we see, is much better than in other studies. Now this is now the study that we did on top or after the pilot study, and you see quite nicely in different colors. Yellow would be the ophthalmic part, the mandibular part. Green would be the maxillary part. Red is now the ophthalmic part, and blue is the GON. Remember, people were sitting in a scanner, randomized, got either an ouch here, ouch here, ouch here, ouch here again, ouch here, and we knew which ouch on what in what location at what time, and then we filtered that and found here in the thalamus a rather nicely each of these stimulations represented on a different spot in the thalamus, bilateral. We also found that in the insula. So on both insulae, the trigeminal and the occipital system has its own spot on the cortex of the insular cortex, and we found some also in the cerebellum. The pictures as such are beautiful, but beyond beautiful, it shows us now that the trigeminal nerve is rather somatotopically organized on these levels, and here now we looked into the brainstem. That was what we were looking for. You see the same color codes, and I hope that you can see that in red here the representation on the brainstem was on different and 6 different levels up the whole brainstem. It's not that we only pinched one little dot in all of these patients. However, 6 parts of the brainstem lighted up for this trigeminal branch. And that holds true for all of the others here as well. This is how it looks if we just merge all these stimulations. And it's amazing, this somatotopic representation on the brainstem level. And it looks as if they are distinct but overlap a little. Problem is we only stimulated one little spot, but we found an activation all over the brainstem. In all these other studies that are published, you see one area and people say this is the trigeminal nucleus. If you look now in a more specified way, then one has to say why 6 different spots and how come, what does that mean? The heh moment in science. And then we encountered a new problem. So we now can pinpoint exactly on the human brainstem where the activations in these different trigeminal nuclei is. On the left-hand side in red, you see just only now the ophthalmic part, 6 different areas. And on the right-hand side, you see the mixture of all the stimulations that we did. So the representations of the trigeminal branches are at 5 to 6 different levels on the brainstem, going from very high up to C2. But we could not separate the individual trigeminal nuclei. So what you want to do now is that you contrast, let's say, all activations of up here of the ophthalmic branch with all activations of V2 or V3. And if you do that, you would find the exact spot where only the V1 is represented, but not V2 or V3. We did that and found nothing. This means for all of these areas. This means that all of these areas activate all of these pinpoints that we did activated the same areas in the brainstem. And if we contrast them, because all of them are activated from these specific sites where we activated, we couldn't find a difference. And that was problematic for us. To remind you, the trigeminal nuclei go down in columns into the spinal nucleus, and the most ventral part would be V1, and the most caudal part, dorsal part would be V3, and in between would be V2. That is how we learn in anatomy how our dermatomes are organized. However, we learn in also knowing from cats and from benchwork on monkeys that the representation on the brainstem of the trigeminals is actually shaped like an onion. And don't know, does that work? Yes. And you can see here now that big mouth, big hands, small area, that the most rostral parts would be now here in this situation around the oral and nasal cavity, meaning this would be V2, this would be V3 in the peripheral dermatomes. On the brainstem it's organized as just one, which is on the most rostral part. The same holds true now for the here auricular part, and the periauricular out part here is the most downstairs. That would be the onion shape on the brainstem. However, we only know that from animals. We don't know that from humans because it's really hard. You could look into dead brains and then see that the anatomy is right, but the function has never been proved in humans because it's hard to do. So, all in all, we can pinpoint each single site of the periphery in itself. We can see that the brainstem representation is rather overlapping rather fast, but we cannot contrast V1 against V3 and find a significant outcome. And then we looked and tried to understand how can we show whether the onion-shaped representation on the trigeminal brainstem is actually functionally working in humans. How could we do that? We only found this rather genius explanation in a book. And this book, you can see here on the left-hand side, you see here that there is the first area of the trigeminals, there's the second, the maxillary area, and the mandibular area. At the same time, it's brainstem onion-shaped activation here. And then they did, in monkeys, differentiate here different parts, 1, 2, 3, 4, and so on. Now what we did, we stimulated, let's see here, up in 4. We stimulated down here in 5, and we stimulated down here in 9. On the brainstem, these representations, proximo, anterior. These representations would be 4, as I said, 6, as I said, which is next to it, 9 to 10, which is next to it. So this part would be activated on the brainstem. If we contrast them, the overlap is so big that we can't find a contrast between those. It's not possible. So the idea was then we try on the brainstem find the 2 spots which are furthest apart, and that would be for the V1. That would be 1. 1 which is sitting down here, and for the yeah. Oh. You think? So bear with me. If we stimulate up here, just the first, second, and third, then it's too near on the brainstem to show. If we stimulate still the ophthalmic part, but on the very back, then we would have 1. And if we stimulate the mandibular part, here is still the 10. And if you go now on brainstem representation, the 1 and the 10 and the 11 are the most part away. And this is what we did. This is what we tried now, to show whether we can now are able to distinguish these nuclei. We did another study, so we didn't publish yet. We didn't publish the pilot study. We didn't publish the study that I just showed you. We did the third study now with 26 people going in there, all of them healthy. And so we had a number of patients of 87. The stimulation site was randomized, of course, and now we stimulated 1 versus, so not here and here, but to the very back where it's still V1, and here down here to get on the brainstem the parts which are furthest away. Doing so now, you can see on the lower part the contrast between V1 and V3, and you see that we can contrast it now, and it's significantly different because so we can show with this one picture that there is an onion shape, functional onion shape on the brainstem areas in human brains. Because we did the first, second, third, and gone, and because you all know that if you block the greater occipital nerve, do a nerve block there, you can help patients with a cluster patient, with migraine, and even trigeminal neuralgia clinically, so they have less attacks. How does it work? If you have a pain here and you block a nerve down here, from animal work we know there should be a functional connectivity between both, but also this hasn't been shown yet. Using our data now, we went for exactly that situation, and we conjunct now. We asked the analysis, is there an area where V1 and the GON work together and are absolutely completely identical? And here in pink you can see that these areas actually exist, and that is the functional connectivity between both. And if you then block one of the both, then the other one will react. We did that with V2 and V3 as well, and beforehand I would have bet that only the GON and the V1, because both are on the very lowest part of the brainstem, would interact, but that's not true. V2, V3 not so much, but V2 and the GON interact a little bit as well. It looks from these data as if doing a GON block would be effective in sinusitis perhaps, or in maxillary problems of the teeth, although there are no data published yet. And then the last thing that we did is we looked into functional connectivity. So we went down to the V1 area and asked the question, is there a functional connectivity between V1 and the hypothalamus? Is there a functional connectivity between V2 and V3 with the hypothalamus and the GON? The answer is yes, there is probably a connectivity, a functional connectivity between V2 and V3 and the hypothalamus. However, it's really strongest between V1 and hypothalamus, and it doesn't exist between GON and hypothalamus. And that explains why people, if the hypothalamus is activated and prepares an attack, this attack mostly in most patients is actually happening in V1 and not in V3. It is possible in V3, that would be the facial migraines, but it doesn't happen with the GON. There were 2 scientific spin-off studies with that. I showed you this is an old study. We looked into the cerebellum. Since I'm doing functional imaging, we always, whatever we did, we always saw some activation in the cerebellum. And we showed these data, we had them in our tables, but we never discussed them because simply we didn't understand them. Pain people woke up to that, and the last 4 years, they found it really interesting how much the cerebellum actually has to do with pain transmission and even placebo response, for example. Now, knowing these data, we looked whether there is a somatotopic representation of the trigeminals on the cerebellum as well, and yes, there is, rather nicely, and to our surprise, it was really overwhelmed by this somatotopic representation for the first, but not for the second and third. So they were all represented, but the first obviously plays the biggest role in cerebellum. That would be the hair effect again in science. I don't know why, and we have to dive deeper and try to understand that. And the last one here, you all know that if you get pain somewhere in your body, your ascending pain system will tell that to the thalamus, and the thalamus will then transmit that to the cortex, and then you know, oh, I should let that fall out, should put my hand away from the hot plate. We have also a descending pain system which always tries to push that down, and the PAG, the periaqueductal gray, is situated in the middle and is actually the most important, next to others, but the most important part for the descending pain system. Looking at our data again, we could show that again the trigeminal nerve and the GON is beautifully somatosensory represented even in the PAG. Until then, until here, the PAG was the pain descending system. And that was thought as a systemic system. That was thought as a system that would just be on or off. And then you would control the pain or you would not. We can now show that even the trigeminal nerve, and of course the rest of the body as well, is somatosensory represented in each single spot of the PAG. That was new. It was just redone, very nicely redone by an Australian group who published that in Science. So, in summary, mapping, we showed and we mapped the functional representation of the 3 trigeminal branches on brainstem level, the cerebellum, the PAG, the thalamus, and the insular cortex. We showed there is a functional co-localization between the trigeminal nucleus and the GON on brainstem level, and that explains when you stop here, do a block here, why headache goes away. And we looked into the functional trigeminal representations and saw that they intermingle very much and overlay as well. But we could show that when we look at the old situation of the onion-shaped representation of the trigeminal on the brainstem level, that really the trigeminal nerve in humans functionally has an onion-shaped manner, and that's the first time that someone was able to show that without anyone dying. It was really a functional imaging study on healthy volunteers. And with this, I thank you for your attention. I'm really sorry that it's such a technical paper. It was important for us to have this technical paper because now we can know exactly on the brainstem where we have to look. And if I now go for people with facial pain, for example, I can put that on the map that we have as a lab-own normal data, normalized data. We can look at our migraine patient, we can do a one block and see exactly where would we accept that and what does it mean. So it is a very technical paper. We did that, and you saw it was 3 studies. Several people were involved. You saw that the Danish group was involved as well, and it took more than 3 years. And I'm really proud that we did that. I find it very hard to present it to you, to be honest, but I'm very proud that it got the Cephalalgia Award. I thank you very much for your attention.
Thank you, Arne. Thanks. Please stay on stage. And thanks for all your research. And thanks also for presenting so clearly something that really could be potentially very complicated. We have the plaque for you. Congratulations.
Thank you.
Congratulations. Congratulations. Okay, let's move to the Jes Olesen Awards. Whereas there's a long tradition with the Cephalalgia Award, this is something new for the journal. This is the first edition of the Jes Olesen Award, and the aim of those awards is to recognize outstanding contribution in headache medicine across both clinical and basic sciences. We had an open call for the submissions starting October last year, ending at the end of February this year, and it was possible to apply both for the Basic Science Award and for the Clinical Science Award. Really, we need to say a big thank you to Professor Jes Olesen for promoting and supporting those awards. A big applause for him. It does not really need any introduction in the field. I'm sure that you all know him and his outstanding career in the field. He has authored more than 600 publications. He was the recipient of the Brain Prize, prior president of the International Headache Society, father of the International Headache Disorder, and this is just a little part of all his contribution. So a big thank you. For your information, we will have those awards also next year, and the call for submissions will be opening 1st October. So encourage all of you who have good research to submit to Cephalalgia and to apply to the Jes Olesen Awards. And now I'm pleased to announce the winner of the first edition of the Jes Olesen Award for Basic Science. The winner is Manvir Kaur, with the paper entitled Sex Differences in Photophobic Behaviours Following Cortical Spreading Depression in Rats. An applause, please. And we have on stage Dr. Caroline Kopruzinsky presenting on behalf of all the co-authors. Please, Caroline.
Good morning, everyone. I hope everybody's listening me well. It's a pleasure for me to present on behalf of my colleagues, Dr. Tally Largent-Mills and her lab, the work that demonstrates sex differences in photophobia, like behavior, induced by a preclinical model of CST in rats. Migraine is known to be a multiphasic neurological disorder, in which aura is one of the phases, and it affects about 1/3 of the population with migraine. CSD, or cortical spreading depression, is also a phenomenon known to be involved or associated with the symptoms reported during the aura phase. Migraine is also known to be a multi-symptom neurological disorder, in which cutaneous allodynia as well as photophobia are the most common reported symptoms by patients. Photophobia is a symptom that affects about 80% of patients with migraine, and it is suggested that patients with aura might experience this symptom even more intense. Migraine is also a female prevalent neurological disorder in which female seems to present a longer and more intense headache symptom, and is possibly also true for photophobia. However, the mechanisms regarding these sex differences, as well as the symptoms associated with migraine, are not fully understood. So the goal of this project and this work was to demonstrate whether the induction of CSD in rats would promote cutaneous allodynia as well as photophobia-like symptoms. However, one novelty of the study is that they not only showed the behavior, the photophobia behavior, they not only evaluated that, but they also were able to demonstrate physiological correlates to these symptoms. So to produce CSD in rats, they did a craniotomy to cannulate the dura mater, and they did cortical administration of artificial CSF or KCL to produce the CSD. They evaluated cutaneous allodynia using von Frey filaments, and they use a 3-chamber protocol that I will explain later to assess photophobia-like behavior. And as a physiological correlate, they evaluated pupil constriction as well as eyelid closure or orbital tightening. So administration of KCL in cortical administration is already a known model of CSD, and it's also known to produce the development of periorbital allodynia in rodents. And as you can see in some of the panels, it was the development of periorbital allodynia was much more robust and long-lasting in female rats when compared to males. So this is the first time that we were able to observe this model of CSD inducing sex difference pain-like behavior. So with these data, the authors decided or questioned whether this would also be true for the photophobia-like behavior. And they use, as I mentioned, the 3-chamber assay to assess photophobia behavior. So for the baseline, they use the same light intensity for all 3 chambers, which is 10 lux, and it correlates to a twilight period. For the test, the authors did have a dark chamber, which have a light intensity of 5 lux, which represent also close to a twilight period. They have a transition chamber, which have 30 lux of intensity of light, and a light chamber with 100 lux of light intensity. It's worth to highlight here that the light chamber correlates to a very dark day and to the amount of light of exposure that a person is commonly receiving at home or at work. So for the protocol of this study, they did collect baseline prior cortical injection of KCL or control, and they did a temporal quantification. They evaluate the photophobia-like behavior at different time points over a time course of 24 hours. So this is the first study that does this temporal evaluation for a long period of time. The first study is to get only animals that did not receive any injection at naive states, and they did evaluate the same time points, and they were able to observe that males already showed an innate light sensitivity, so they preferred the dark chamber during the time points evaluated. So they become, or we can conclude that they already start sensitive. However, they observed that females show a very balanced distribution throughout the time courses evaluated. With that, they induced CSD by cortical administration of KCL. And in males, since they are already they prefer already the dark chamber, the authors were not able to see any difference in comparison to administration of control or KCL on the time spent in the light chamber, in the aversion index calculated from the baseline, and the entries in the light chamber. However, when they give these cortical injections to females, to either control and KCL, was able to produce a decrease of the time spent in the light chamber, starting right after the cortical injection. This is very important to point out here. They were able to see an aversion index, and as well as they enter less in this compartment during the test. So these point out that females are demonstrating photophobia-like behavior. So looking at the dark chamber, the authors were not able to see any difference compared to any treatment in males. But females, they do prefer to stay in the dark chamber or go to the dark chamber. And they associate this behavior to dark-seeking behavior related to photophobia. So they spend more time in the dark chamber, they have a higher dark-seeking index, and they enter less, so they spend more time there. Regarding the transition chamber, the middle chamber, they were also not able to see any difference between treatments in males. But female mice, interestingly, they do spend less time in the middle chamber. And what does that mean? It means that they are already experiencing photophobia, and they have a response, a very quick response. I'm bothered by the light, even in the middle chamber, and I will go to the dark side. So these prove that these animals are experiencing photophobia-like behavior. Here the authors demonstrate that since they observed that either control and KCL produce light aversion, they were able to stratify the data from animals that were not injected, and they demonstrate that the number of animals that receive KCL that have light aversion is higher, the female animals are higher than the control. And as well occurs the same situation in the dark-seeking behavior. Animals, female animals that receive KCL, there is a higher number of these mice that have preference to the dark chamber, proving that the comparison between the control and KCL group underscore the role of CSD in exacerbating light sensitivity. And they also point out that this light sensitivity observed in control could be due to the pinprick that is used to perform the cortical injection of these two components. To prove, to confirm that KCL induced light sensitivity, the authors also perform area under the curve analysis of the time spent in the light chamber and in the dark chamber. And again, nothing was observed in males because they were already sensitive to begin with. But however, female mice with either control and more pronounced with KCL, they do prefer less the light chamber, and the opposite only with KCL. They prefer more the dark chamber. So here there are some summary of the data. We were able to demonstrate that KCL produce a photophobia-like behavior more pronounced in females. And this protocol used was able to demonstrate a temporal change in which the light aversion was observed right in the beginning following the cortical injection, and the dark seeking was observed at later time points. The next set of experiments was to observe whether there is a physiological correlate to photophobia in rodents, not only in comparison to the behavior observed. And they decided to assess the pupil constriction, which was calculated using the ratio of pupil to iris diameter. So first, the authors did not see any sex difference in the pupil constriction at the baseline. However, when they inject KCL as well as the control, they were able to see in males a very robust pupil constriction at 60 minutes post-injection. So it was a brief behavior. In males, this effect was more pronounced. The pupil constriction was observed at 60 minutes, but it persists over 180 minutes post-injection. So this parameter has been associated with the light aversion observed in the behavior, which in female starts right after the injection, about 60 minutes post-injection, and persists throughout the time points evaluated. In addition, the authors evaluated the orbital tightening or the eyelid closure, which was calculated by vertical palpebral aperture relative to a reference point. It is a point that even if the angle of the picture of the animal would change, they would be able to calculate this parameter. So again, on baseline and before injection, there was no sex difference. And after control or KCL injection in male, they were not able to see orbital tightening. However, when they give the same injections to female, they were able to observe an increase of orbital tightening only in females that receive KCL at later time points, 1 hour and 80 minutes post injection. So these physiological seems to correlate to the dark-seeking behavior observed in photophobia assessment. So to conclude, the authors demonstrate that this well-known model of CSD was able to produce cutaneous allodynia in both female and male mice, with more pronounced and long-lasting allodynia occurring in female. They were able to observe that this model of CSD also produced a light aversion in female, which has been correlated to the pupil constriction as a physical correlate, as well as dark seeking, which occurs at later time point after KCL, and has been a correlation to the physiological symptom as observed as orbital tightening. So on behalf of the authors, I would like to thank for the award, which is an honor, and thank you so much for your attention.
Thank you. Yes, please come on stage to handle the award. Professor Loles. And congratulations once again.
Thank you.
Well, I think this was the first time we gave out the. You found a very able recipient, and I think it looks good for the future. Remember that this is for young scientists. This prize. Would you want to tell people about the conditions?
Yeah, we will have all the conditions in our call. It's for original research. Each researcher can submit one single award, and we prioritize younger scientists. Yeah, thank you. Please, yes, stay on stage. So, yeah, you can take a seat here. Okay. Let's move. And now it's my privilege to present the winner of the Jes Olesen Clinical Science Award. And the winner is Dr. Miji Lee with the paper entitled Subtype Shift, Relapse Rate, Risk Factors of Frequent Relapse in Cluster Headache, a multicentre prospective longitudinal observation. Please, Miji, come on stage. Big applause for you. Miji is assistant professor of neurology at Seoul National University College of Medicine. She her main field of research is migraine, but also cluster headache and other types of headache. She has already received huge recognition for her contribution in the field. She is one of the associated editors of the journal Cephalalgia, and so Miji, congratulations for this additional award, and please, the floor is yours.
First, I would like to thank Professor Jes Olesen, not only for this prestigious award, but also his lifelong dedication and scholarly contributions that had already enriched our field and inspired me personally when I first started my journey in headache medicine. So thank you. And I would like to share this recognition with all of my collaborators. Some of them are already here, and I'm here on behalf of the KCHR collaborators. So these are my disclosures, and none of them are related to this study. So it all started from questions from our patients. Patients ask like this: will this condition eventually remit over time? I don't know. This bout started earlier than expected. Is this a good sign or a bad sign? I don't know. My bouts became shorter than before. Does this mean I'm toward the end of the disease? I hope so, but I'm not sure. So little is known about the prognosis of cluster headache and their prognostic indicators. What is the prognosis of cluster headache? First, it can be long-term remission, which all of us hope. But it requires long-term observation to get this outcome, so it is more suitable for retrospective cohort. So there are a few retrospective studies, including mine. The second is development chronic cluster headache, which all of us is afraid of. So there's a few study and some a very nice study from Europe about a conversion from episodic to chronic cluster headache, which is called secondary chronic cluster. But the incidence of primary cluster headache, primary chronic cluster is rarely investigated. So there's only one retrospective study on this topic. The second is about relapse. This is something that happens in almost all patients, not only for very lucky or very unlucky patients, but many of patients have relapses. But there's nothing we know about the bound relapse. So it needs a prospective observation of episodic cluster headache. And we also need detailed baseline vectors to identify risk factors. We aim to investigate the prognosis of cluster headache in a prospective 5-year longitudinal observation of a multicentre cohort, with a special focus on the incidence of primary chronic cluster headache, subtype shifts from episodic to chronic, and relapse rate of episodic cluster headache, and the prognostic factor that is predictive of frequent relapse. So this is the main theme of the Korean cluster headache registry, which is very, very productive. So it is an investigator-driven prospective multi-center registry. It was conceived and designed in 2016, and I'm really happy to present its results in about 10 years later here now. We have 24 investigators in total from 19 medical centers with PI, Professor Sujin Jo, who is sitting right there. And we have two study periods. One is KCHR1 and the other is KCHR2 with different research focus. So this long-term study is part of the KCHR1. We are very proud of this project because we have 479 patients in total, and we have 21 publications from this registry. So for this particular study, we have very complex design, but I would like to make it more simple. So at baseline, we enroll patients and classify patients into episodic and chronic based on temporal profile of the current bout, and collect data on many things like current bout characteristics and temporal changes of previous bouts and treatment profiles. After 2 to 4 weeks, we reassess subtype again, because some of them have already remedied, but the other can have ongoing disorders. So we follow the baseline bout to the very end of the bout. So reassessed subtype and collected data regarding some time-related factors like circadian rhythmicity, we observed it, and treatment response and the remission date. After 3 months, we again reassessed subtype based on the observation if they are not remedied at week 2, and we collect data on remission date and relapse. And from the 3rd month, we started to collect annually about the data on relapse, number of relapse, and date and duration of the observed relapse. So this summarizes the data we collected. We did not calculate sample sizes a priori because we wanted to collect every consecutive patients, but we did post-hoc power calculations. And we have different patient composition for different study topics because the subtype shift of the current bound is eligible for all patients. But the incidence of primary chronic cluster is eligible for patients with new onset cluster headache whose subtype was undetermined at baseline. So we excluded those who already have a long-standing history of chronic cluster headache to avoid any overestimation and possible bias. And to calculate a relapse rate, we considered patients with episodic cluster headache who were enrolled during an active bout eligible. And the relapse rate was calculated by dividing all the observed relapses by person years of follow-ups. We performed Poisson regression analysis to estimate and compare the correct incidence rate ratio of relapse using offset term accounting for the different follow-up periods among patients. And we made 2 multivariable models because some factors are available for all patients, like static characteristics, but there are some factors they are which can be only obtained in patients with 2 or more bouts, like temporal change patterns and seasonal rhythmicity. So moving on to the result, we had 295 patients for the KCHR1 cohort. Among them, 262 patients were enrolled during the active bout. We had 58 first-onset cases. So you can see here the classification into episodic and chronic changed from the initial classification to the post-observation classification. So when we take a further look on it, so we can see there are much more shifting from the initial to the post-observation period. And we were able to get 3 additional cases which has shifted from episodic to chronic. So the prospective measurement of the secondary chronic cluster headache is 1.3%. And similarly, we got 2 additional cases which had chronic cluster headache developed from the first onset bout. So the incidence rate of primary chronic cluster headache is about 4% in our first onset cases. Moving on to relapse rate, we have 244 study population eligible for this analysis. They underwent average 5.9 follow-ups over 4.2 years per patient. And you can see here the completion rate over time. So it's a little bit decreased here, but we had our so many efforts to get those results. And this figure, you can see plots of every relapse we captured. So in the left panel, you can see the relapse in first onset cluster headache, which is much more less. And on the right panel, you can see many relapses we had captured in patients who had 2 or more lifetime bouts. So overall, we obtained 0.29 relapse rate per person year, which is corresponding to 29% annual risk of relapse. The first relapse was occurred after 20 months after the baseline bout. And the relapse rate was much more lower in first onset cluster headache than those with recurrent cluster headache. So I'm gonna go into details on this busy slide, but I'm gonna summarize the findings. So to summarize, we found some protective factors for relapse, including older age, longer disease duration, first onset cluster headache, and regular alcohol consumption. And we found seasonal rhythmicity, shorter bout intervals, and increasing attack intensity over time are risk factors for frequent relapse. So to wrap up all the findings, the incidence rate of primary chronic cluster headache was found to be 3.8% in our cohort, and subtype shift occurred from episodic to chronic cluster in 1.4%. And relapse rate of episodic cluster headache was corresponding to 29% of annual risk, which is significantly lower than estimates from the retrospective records, which was reported in about 1 bout per year in most publications, including our own publication. So it may suggest some difference between the retrospective studies and the prospective studies. And I think this suggests some disease activity of cluster headache evolves over time and then declines, because we observed less relapse in first onset cluster headache and then more relapse, and again less relapse in patients with advanced age and longer disease duration. And regular alcohol consumption was interestingly to be found as a protective factor, but this doesn't mean any causal relationship, because there can be some kind of behavior modification. And finally, seasonal rhythmicity and increasing attack intensity over repeated bouts can be markers of higher disease activity. I'd like to thank again Professor Sujin Jo for her leadership and amazing contribution to this project, and all of the investigators, my lab members, and most importantly, our patients. Thank you.
Thank you, Miji. Thanks. This is a very important study that can for sure improve our dialogue with the patients. And so really congratulations for your research and for this award. Congratulations. So we are now at the end of this session. I wanted to say a big thank you to all the Cephalalgia teams that works behind the scene, and to all of you for being there, for attending the session. Enjoy the final part of the conference.